Again, good afternoon. Thank you all for joining us today. Please note that this session is being recorded. If you do not consent to being recorded, you are asked to drop off the call at this time. Thank you. Again, good afternoon, and thank you for joining us today. Welcome to the 5th Emerging and Re-emerging Infectious Disease Peer Learning Webinar Series. My name is Adriana Marzette, and I'm a Public Health Program Coordinator with the National Indian Health Board. I will be moderating today's session. Today, we are joined by Ms. Ginger Parker-Southard, and she will discuss the impact of COVID-19 on EBCI's Syringe Services Program and how the program addresses ongoing risks related to infectious disease, overdose, and injection drug use while adapting to COVID-19. Now, before we start, let me review just a couple of our housekeeping. Attendees are required to sign in and sign out to receive CME, NCPD, and CHES continuing education credits for attending today's webinar live. Today's session is being recorded again. So if you do not consent to being recorded, you are asked to drop off the call at this time. All of our webinars will be posted to the NIHB YouTube channel. I will send an email once that webinar is available. We encourage you to enter questions into the chat box throughout the webinar. Once we get to the Q&A portion of the webinar, you will be asked to either unmute yourself or you may type your question in the chat box. However, we do ask that you keep your mic muted during the presentation. If you have any technical questions, please send me a message directly. And with that, I will read our bio. Today, we are joined by Ms. Ginger. She is a member of the Eastern Band of Cherokee Indians, EBCI, and manages their public health syringe service program. She received her MS at the Western Governors University in Nursing Leadership and Management. She has been a nurse for 16 years and has worked in every setting, from outpatient to the burn ICU. And I would also just like to take this moment to just say, Ms. Ginger is having some internet issues, so she would not be on camera today, but she is able to hear us clearly. We were able to work that out. So she would not be on video just because her bandwidth and her sound and audio works better without, and we all understand how Zoom goes. So please, thank you for working with us. So without further ado, I now pass it over to Ms. Ginger. Thank you.
Hello, everybody. Thank you for this opportunity to speak today about harm reduction. We're going to talk about the superheroes of disease prevention in underserved and marginalized population of the injection drug users. Next slide, please. These are our learning objectives. We're going to define the goals of harm reduction programs, understand the role of harm reduction programs in preventing the spread of communicable diseases, and we're going to understand the importance of tracking data related to program initiatives and goals. That is the pot of gold at the end of the rainbow. Everybody wants to know what the program's doing and what impact it's having. Next slide, please. So harm reduction, as you all know, is a huge topic. It can be anything from wearing seatbelts to baby-proofing your home to wearing non-skid shoes. I mean, it's huge. So for the purpose of this presentation, we're going to refer to harm reduction as it relates to substance use, specifically injection drug use, and the prevention of the spread of communicable diseases. Some abbreviations that you're going to see in the presentation are going to be SSP, which refers to Syringe Services Program, IDU, which refers to injection drug user, HCV, which refers to hepatitis C, and MAT, medication. Next slide, please. So here's a little history of harm reduction programs. SSPs actually started in the mid to late 80s when the HIV epidemic was on the front page of every news. It was all over the place. People were scared to drink out of water fountains. They were scared to touch each other. And it started because they saw a rise in cases among people that were injecting drugs and homosexual men. But they started these programs illegally, which means they were not allowed by any government or state to be handing out clean injection supplies. So a lot of programs started out of the trunks of cars. They started out of homes. They started out of anywhere people could hide, essentially, to give out these supplies because they were going to get arrested for it if they got caught. These programs are surrounded in stigma and misunderstanding, and they have been since they started. People tend to think of them as programs that enable and promote substance use, and it's actually quite the opposite. Next slide, please. So the goals of harm reduction programs, or SSPs, focus on keeping people in active substance use as safe and healthy as possible. They are not geared to get people into recovery or treatment. We are here to meet people exactly where they are, wherever that is, and offer them a safe place. They need to be able to come and talk to us about issues they may be having that involve domestic violence. They may have infections or skin issues they need a public health nurse to look at and assess. We need to be able to give them that space without judging them. We can't put any requirements on using the program. There's no requirement for going into recovery. There's no requirement for decreasing substance use. There's no requirement for even seeking medical care. All we can do is suggest and offer those resources, but this is a judgment-free place, and it's safe to discuss anything they want to discuss. Harm reduction programs should be able to serve the whole community. And you're not going to serve the whole community in the same way that you are serving someone who's using substance. But what we can do is provide education. We can go out into the community and talk to families, talk to community clubs, churches, and just give education on what the program is for. And substance use, we talk about mental health, we talk about trauma, we talk about anything they want to know about. We can talk to summer camps. We go to summer camps and talk about substance use. So it really needs to encompass the whole community, and that gives the whole community a sense of ownership. And when you own something, when you've helped create it, when you're invested in it, you don't want to see it fail. So it helps decrease a lot of the stigma around the program, and it makes us accessible to anybody. We allow community members to come to our program and just look around and see what we do. They get to see the supplies we give out. They see the paperwork we keep. They go through the same process just to see what it's like as somebody that's enrolling in the program. These programs also have a huge impact on communicable disease. As you'll see in a few slides later, the number of cases of Hep C and HIV have in communities with syringe programs have decreased dramatically, over 50%. And that's really what we want to do. We want to keep people as healthy as we can until they are ready to make the decision, their own decision, if they choose to go into recovery. We want them as healthy as they can be. So communicable disease is just another word for something that's easily spread. And a lot of harm reduction programs are going to focus on HIV and Hep C. We also contribute to the decrease in spread of MRSA, chlamydia, gonorrhea, all your STIs. If we can get people treated, that decreases the spread of those diseases. Endocarditis cases go down, and endocarditis is an infection of the heart lining, and it can be very expensive to treat. It usually ends up in some type of valve replacement, and ICU stays in the cardiac ICU. And the cardiac ICU is extremely expensive. Next slide, please. So here's some stuff that we know. Syringe services programs are evidence-based practice, which means they have been proven to have an impact on the decrease in medical care costs related to communicable diseases such as Hep C and HIV, and a decrease in case count. People that use an SSP are more likely to seek medical care for illness because when they come into the program, or if you're meeting them out on the street, they connect with whoever their peer is, the outreach worker. And by that connection, it opens up a conversation about, look, you look like you've got an infection or something, you don't look right. I can tell you personally, I sent 3 people to the ER from our SSP, and every one of them ended up in ICU with endocarditis. They survived it, but it's just making that connection and giving them the non-judgmental advice of, look, you might want to get this checked out. We're not judging you for it. We're not telling you this is what happens because you're injecting. We're letting you know that you need medical care. Participants that use an SSP are less likely to reuse or share injection supplies because they don't need to, right? If we're giving them what they need, they shouldn't have to reuse or share. They've got their own stuff. It's clean. They use it, get rid of it, and get something new. In Europe, SSPs decreased Hep C cases by 56%. Our program on the boundary saw a 59% decrease in Hep C cases from 2017, which is the year before we officially opened, to 2021. And that is huge. That is absolutely huge. That kind of decrease, it saves lives, and it also saves a lot of money in healthcare costs. And unfortunately, for some people, the benefit of saving a life is going to be overshadowed by how much money you're saving the healthcare system. So it's a double-edged sword. You've got to focus on both of those aspects when you're reporting about your program. People always want to know about money. That's the bottom line. How much does it cost to run the program? How much is the program saving? You will never see a monetary gain from these programs because there's no way to get that. What you're going to see is a decrease in medical care costs and a decrease in infection. Next slide, please. I'm going to butcher this name and I apologize, but a study conducted by Ijiyama looked at the impact of syringe services programs by themselves, syringe services programs combined with MAT, and no intervention at all on the cost of Hep C cases. Now, this is the cost of treating Hep C, a medical cost. And what they found is if you just had a syringe program in your community, no other intervention, just the syringe program, you would save $363,821 per Hep C case. And that's compared to not having a syringe program. When you combine a syringe program with an MAT program, the studies showed that 72 cases of Hep C were prevented out of 100 injection drug users, and that is huge. If you prevent 72 cases of Hep C, then you've also prevented 72 people from spreading that virus. And Hep C can be spread to people that don't even use injection drugs. If people are couch surfing or they're transient and they're just staying from home to home, if they leave a toothbrush or a razor or anything like that, you could spread it to someone who doesn't even inject. Next slide, please. So a model study is where they take an event and they add interventions or add, I guess it would just be, they would add interventions to the study and kind of predict what would happen. Model studies are really neat. This model study is listed in the references. If you get a chance to read it, it's really interesting. But this model study took the 2015 HIV outbreak, which was in Indiana, and it's a documented outbreak. The data collected demonstrated that if one new HIV infection were introduced into the injection drug user population, that's what they were looking at, is to see what would happen with one new case. The study broke it down into 3 results. One of them was proactive, which was defined as having a syringe program already in place before the infection was introduced. The second was reactive, which was introducing the syringe program after the infection was introduced into the population, and I think it was 10 months. The third was having no intervention at all. We know we've got this case, but we're not going to do anything about it. Next slide, please. What the study showed, and this is predicted, this is not, it's a model study, so it's a predicted outcome. If you had no syringe service program, no harm reduction program, there would be 176 new cases of HIV in a 5-year period. Now, that may not sound like a lot, but if it's a small community, or if you're one of the 176, it is absolutely life-changing. That is a huge number. If the community were proactive and had a syringe service program or harm reduction program in place prior to the HIV infection being introduced, there was a 90.3% decrease in new cases. That is amazing. And this is a simple intervention. It's not something that's going to be earth-shattering or something that you have to construct this whole big, elaborate program or plan for. These are basic. You need to give people clean supplies. You can get them through NASN or some grants fund part of them. But to have that type of proactive result is what harm reduction is all about. If there was a reactive response, which meant they started the harm reduction program, the SSP, within 10 months of the infection, there was a 60.8% decrease in new cases, which is still a huge decrease. So even if the community is not willing to be proactive, if we can get the education out after the infection is identified and let people know what the evidence has shown with harm reduction programs, then we still have a chance of decreasing those infections by 60%, which is fabulous. I mean, to me, it's a no-brainer. But I'm going to tell you right now, I'm very biased towards harm reduction programs, and I can't apologize for it. I just am. Next slide, please. So as I said before, SSPs are invaluable. They really are when it comes to preventing communicable disease. And we're focusing on Hep C and HIV, but to be honest with you, programs, we can identify people that have not been treated for STIs. If we get those reports from the hospitals and the counties, and we know in their history they have substance use, then we can contact the harm reduction program and say, if this person comes in, call us and let us know, and we will try to educate them on why they need treatment and encourage them to go to the hospital or the clinic or wherever they can get treatment. The relationship that's built between the client and the outreach worker, those are healing, nurturing relationships. They are non-judgmental. We have peer supports that work in our program, and a peer support is priceless. I can't say enough about them. If you don't have peer supports in your program and you want information about what that looks like or anything, just let me know and I'll get you the data that we have on it. In North Carolina, to be a certified peer support, you have to have a year of drug abstinence or sobriety, and then you have to go through a certification process and 40 hours of extra kind of like CEUs. And then you get your certificate. So I encourage peer supports. I love peer supports. I wish we had more of them. I think we should have them stationed in the hospital, in the jail system, in social workers, family support. They are just invaluable. And like I said before, our communicable disease nurse is amazing when it comes to trying to track people down to get our treatment for STIs and Hep C too, and Hep A and Hep B. What happens in our community, because we are not a county and we are not recognized as a county by the state, we function through our Indian Health Services system, which is our hospital that's on the boundary. And we will get the reports of the positive Hep A, Hep B, Hep C, STI. The communicable disease nurse will check and see if they've had treatment. And if they have not had treatment, then the hunt is on. We try to find people. If we can find in their history where they have a history of injection drug use, then we contact the Syringe Services Program, the harm reduction program, which is embedded in our public health program. I think every public health program should have a harm reduction program. It should just be standard. We get rid of the stigma and move on. We will, what she asks is that if the person we're looking for comes into the program, that we get a phone call, and either she can talk to them on the phone or go over there and talk to them in person and explain their diagnosis, what treatment's going to look like, how they can get it, and hopefully the outcome. And it takes down that barrier. A lot of our participants don't like going to the hospital. They're labeled as frequent flyers if they go through the ER. There's a lot of stigma. There's just a lot of bad blood there. So we try to bridge that and integrate people back into healthcare. It's not always easy though. This has been going on for years and we're relatively new. So it's a challenge. It's a lot of work, but it's worth it, especially when the whole team works together. Next slide, please. Okay, COVID. Oh dear. So this section is about what happens when harm reduction services are interrupted or if programs get shut down. As you know, they're controversial. There's stigma around them. All it's going to take is one event, maybe somebody under 18 coming in and we have no age limit on our program. We do not ask for ID when they come in. So if someone under 18 comes in, we have a protocol we follow for people that are under 18, but we don't deny them services. So that could be really controversial. It can cause a lot of pushback in the community. And all it's going to take is one event, a syringe being somewhere and somebody getting stuck, and it's going to come back to the harm reduction program. So there was another modeling study done, and it talked about the impact of closure or interruption of services on HIV infections. And it also used the outbreak in Indiana, which was in 2015. It showed that 2% of the population after the outbreak were likely to share syringes, as opposed to 32% of the people who were not enrolled in the program. Does that make sense? Did I read that right? Oh, okay. 2% of the people out of the injection drug user program that use the harm reduction program would share syringes. 32% that were not enrolled in the program would share syringes. Next slide. The data showed that closing the program would cause a 61.6% increase in HIV cases in a 5-year time frame. That is a huge increase in 5 years. The impact of closing would also affect people who did not inject drugs. They were predicted to see 3 more infections of HIV if the program remained open. Next slide, please. So this is what we had to do to adapt to COVID-19. This is the front porch of our program. Normally, our transactions, our people coming in to get supplies would take place inside the building, but because of COVID-19, we could not allow people in the building. So we had to set up, and you can see that there was a 6-foot barrier. The outreach workers would sit at the table. The people that were coming to get supplies had to stand behind the chairs. So as you can see, this is not going to be conducive to talking about domestic violence, sex work, any type of abuse, any type of need for housing. They're just not going to talk about stuff like this out in the open. We also saw an increase in overdoses during the pandemic. We saw a decrease in visits, and a lot of that was due to transportation issues. People are not going to climb in a car full of people if they think they're going to catch something. So a lot of people didn't have transportation, so they couldn't make it to the program. The pandemic took a population that was already ostracized and isolated and made that 10 times worse, because now everybody's looking down the road and we're seeing people walking up and down the road and they think they've got COVID. It was a mess. It was a mess. And we learned, one of the things we learned is that we had no housing for transient population, especially in using substance. Some people can start going through withdrawal within 3 hours of the last time they've used. So we had no housing because nobody's going to house somebody that's actively using, and no families would take them in. A lot of those bridges had been burned, and a lot of them didn't want to risk getting sick themselves. So it was a real challenge to try to keep people isolated and try to get them a place to stay where they weren't spreading the virus if they were positive. Next slide, please. During the lockdown, as I said before, a lot of programs were closed. There wasn't enough PPE for people to use at the syringe programs to safely test people. Our program tried to set up a testing event with our public health nurses, and we didn't get that many people that were willing to test. We got even less people that were willing to get vaccinated at the site. But what we did notice is that when we had pods out in the community, vaccine pods, a lot of the participants from the SSP came to those pods. So we actually had more people vaccinated than we thought we were going to get because they were not participating at the actual syringe service program. Next slide, please. Okay, so collecting data and tracking it and reporting it is going to be vital to sustaining a harm reduction program. They're already controversial. So everybody's going to want to know, what's your program doing? Has this been impacted? One of the things that we used when we started our program was our Hep C rates. We were at an epidemic level of Hep C for our community. So what we did is presented tons of data that showed that syringe service programs decrease the spread of disease. How they do it: by giving clean injection supplies, by getting people enrolled in treatment programs, by getting people tested. And one of the program goals was to decrease the amount of new Hep C cases, which, as you saw in the previous slide, has happened since the program opened. But we track that information yearly. A slide coming up will show some of the forms that we use. And we track a bunch of data. We report on anything. We report on domestic violence reports that come through. We report on Narcan, overdoses, anything that, when you do your community assessment prior to opening your program, anything that is an issue for your community, harm reduction needs to be the answer if you're going to report on it from the program. Syringe litter was another thing. We had a lot of people were finding needles out in the community. So we committed to being the ones that would be responsible for cleaning that up. Next slide, please. These are our forms that we use. We have a form for the very first time that people come when they're getting enrolled in the program, and this is what it looks like. The top part of it is going to ask them what age they first used substance, and that is any substance. We ask if they're smoking pot, if they're drinking alcohol. And the reason we ask that specific question is to find out at what age we need to start doing our intervention and what topics we need to be covering. We have had people come in that have reported alcohol use at 3 and 4 years old with their parents. We have had people come in that could tell you at 8 years old what a Oxy looked like, what a Percocet looked like, and how to crush them up, what to mix them in. So our kids are getting exposed at unbelievably young ages. Our program is for anybody that comes to it, whether they're EBCI enrolled or not, but we do track enrolled versus non-enrolled participants. And how we do that is we put an E at the end of their ID number or an N. If it's got an E, they're EBCI enrolled. If it's got an N, they're not. This is an anonymous program, so we ask them for some letters and some numbers, and then we put the E or the N at the end of the ID number. And we also report on how many enrolled members were serving versus non-enrolled, because that's one of the things people wanted to know. And next slide, please. This is a form that gets filled out every time they come in. If they come in 3 times in one day, they're filling this out 3 times. This is going to ask them what substance they're using right now. We try not to ask them what their drug of choice is, because it may be cocaine, but they can't afford cocaine, so they're using heroin. So we want to know what they're using right now. Anything that they're using that's not listed on there, we write it in. We ask how many times they're injecting per day, how many syringes they brought back, and how many that were given out. We do not hand count anything that's returned to the program. We do it by estimation, and our kiosks are weighed. We count how many Narcan kits we give. We have injection and nasal Narcan. And we also count how many doses were used if they responded to an overdose. Next slide, please. Oh, well, I guess that's it. These are the references. That study, the model studies in there. If y'all have time, it's a great study to look at. It's got a lot of information in it, and it's just neat to see how they would predict the outcomes. Thank you. If you have any questions, just let me know. If you need any more information on our program, if you want information about the kiosks we have out in the community, then just let me know.
So at this time, we will open up for questions for Ms. Ginger. So if you have any questions, you may now either, so we do have your first one is, what was the ratio of enrolled versus non-enrolled?
I don't have that exact number here. I can tell you that we see more enrolled, and I don't have the exact percentage, but we do see more enrolled than we do non-enrolled. And that's because a lot of the non-enrolled people that come through, they're just passing through. We have people that come from Tennessee and Georgia, which are not our home state. We're in North Carolina, but a lot of them are just passing through, and they pass through a couple times a year, depending on the weather when they're traveling back and forth. But the majority of our participants are enrolled, EBCI enrolled.
Your next question is, how many kiosks do you have, and what are in them?
We have 20 kiosks out in the communities. We put them, they have to be on tribal land, so they're set up in each community. And what they do is, it looks like a mailbox. It looks like one of those blue mailboxes that you drop letters in at the post office. And they put in our kiosk, they're for syringe disposal. So they drop their syringes in there instead of throwing them on the ground. People put diabetic syringes in there. They put their Humira injection pens in there, and we collect those to keep. That was one of the promises we made, was to keep syringe litter, or limit the syringe litter that in the community. And that's what the kiosks are for.
Your next question is, how has the BIA law enforcement been supportive?
So we had, our law enforcement is a tribal program. We had a lot of pushback at the beginning, to be honest with you. We had a limited immunity clause with our program, and which means that if people got caught with paraphernalia or residual in any syringes, that if they had their enrollment card if they had their syringe program enrollment card with them, they were not supposed to be charged for paraphernalia. That did not go over well. It took a lot of education. And we still have to go back every once in a while. We did have, when we first opened, we had a lot. It's a great place to find people that have active warrants. So we did have an issue with police officers waiting at the stop signs or driving up and down the road in front of the program. And it just took a lot of education. Our secretary had to meet with the chief and the chief of police, and, it was more than one discussion. But now I think they're more accepting of it. Some of them. We do give Narcan out if they want it. We provide education on when to use it and all that stuff. If they need anything from us, we'll give them Sharps boxes if they need it. But it's ongoing. That's not going to ever be a one and done.
And so speaking of feedback, the next question is, do you hear feedback about the paperwork being burdensome? Data collection and SSPs is something that this particular program has struggled with due to the lack of time and manpower to collect much of the information.
We have not had any pushback from our participants. And the reason is we made it very clear when we opened the program that we had to have this information in order to stay open. Our program is mostly tribally funded. So at any time, they could say, you know what, this isn't working, and shut the doors. So we made it very, very clear from the beginning that we had to have this data. And we haven't had anybody that has refused to fill it out or didn't want to fill it out. They've been very, very willing to participate in that. And they give us tons of feedback. We send out surveys and ask them what they want. And that's a huge way to get their feedback. If you can send out a survey and say, what do you need? We just sent one out for an overdose response team and asked them what they wanted to see in that. And they will tell you, I promise you, they'll tell you if you ask.
So the next one is a 3-part question. So I'm just going to go by question to question. The first part is, what would you say is your biggest barrier when you open the kiosk for community use?
That we really didn't have a whole lot of pushback on our kiosks because they're for syringe disposal. We don't have kiosks for Narcan dispensing or anything yet. We had some issues, believe it or not, from our EMS department. They didn't really think they were a good idea. But honestly, it's education. And we just went out and pounded the ground and said, this is, if you want less syringe litter in your community, and they can put anything in there. We don't tell them it's only syringes. We'll find tourniquets in there. We'll find cookers. We'll find anything in there. If you want less of this in your community, in your parks, in your playground, or in your cemeteries, and all the stuff that they were complaining of finding it, this is a solution. And that's the way we presented it. And people use them. I mean, we weigh the amount of waste that's found in those. So we don't hand count anything. We just weigh the bins, but a lot of people use them. We have an enormous amount of waste that's collected in those.
So the second part of the question you answered, the question was, have you had any community pushback? And you said no for the community pushback, but EMS was not originally on board. The third part of their question is just a recap of what resources do you provide for drug users and what additional programs do you all have in place to support them?
Because we're an anonymous program, we can't actually send an official referral. What we do is tell them about the services we have in the community, our MAT program, our inpatient program. We provide on-site vaccination for Hep A, Hep B. We provide, and COVID and flu. We give them any vaccine we can give. We take over there and offer it to anybody. And believe it or not, we get a lot more participation than I honestly expected. But we provide information on how they can get food. We have a lot of donations that come in of canned foods, Pop Tops, those kind you just peel the top back, because a lot of our program does not have secure housing. So they have no way to cook. We provide bottled water. We provide winter clothing, gloves, scarves, toboggans, socks. Hygiene kits are huge. We just started giving out pregnancy tests for people to use, or, if they feel like they need them. We give out condoms to everybody, if you pull up and turn around the parking lot, you're getting a condom before you leave. I mean, we've got dental dams, we've got any type of service we can give them to prevent an STI, we give those.
Our next question is, did you offer community-wide education? And if so, did you have specific education for elders, meetings to address concerns? Did you host any town halls?
Yes, that education's ongoing. We just went a couple weeks ago to give community club council education on Narcan and some kits to leave at the community clubs. What we did is we surveyed the community and said, what do you want to know? And with that information, we had people, they would contact us and say, can you come speak at this church? And I went to a couple of churches and explained what the program was for. And churches are, they can be tough because there's the whole moral compass that goes with substance use and you know, a lot of stuff. So it was important to present facts about the program and stick with the facts as much as possible. It's hard not to get into a moral debate over it, but when it comes down to it, that's not what the program's about. The program's about meeting people where they are and giving them whatever we can to help them stay as safe and healthy as they can. We have different programs for kids related to substance use and different programs related, like if you're presenting it to local government or if you're presenting to, we did go to our elders. We went to the sewing club in Big Cove one time and talked to them about the program and about Narcan. So you do have to adjust it based on your audience. But if you keep it fact-based and answer their questions, I got into one heated debate it was basically a town hall. And that's really the only one that I've had that's been super negative. Now there's been pushback. There's been a lot of, they don't agree with what you're doing. You're enabling, you're teaching kids to use drugs. There's a lot of that. And you just stay on the course, use the facts and break it down. I got into a discussion about, there was concern about children being in the home with people that use substance. We do not call the police if somebody comes to our program with a child, unless that child looks to be abused or neglected. If that child is healthy and interacting and fed and clean, we do not call the police. And I compared it to leaving a child in a home with cigarette smoke and knowing the long-term health risks that was going to pose, bronchitis, COPD, asthma. If you take the stigma away from it, honestly, there's no difference, right? I mean, they're being exposed to the secondhand smoke. They're not being exposed to, hopefully, they're not injecting. Does that make sense? So if you get pushback, just try to break it down without the stigma and just make it as relatable, I guess, as possible. But there's always going to be pushback, and education's ongoing for everybody.
Next question. How do you address or educate this to adolescents who live on the streets?
This is where your peer supports are your A-team. I mean, if you can find a peer support to talk to kids, we have a juvenile services program on the boundary, which helps kids that are in the judicial system. They've been arrested, they're doing work detail, or they're trying to get their community hours or whatever. And the best impact and the best response we've had is when we've had our peer supports go and talk to them and let them know what their life is like. I mean, these are adults now, but they lost their kids, right? They lost jobs, they were homeless, they couldn't stay anywhere, they were sick half of the time. But to have somebody with a lived experience convey that and talk to people, because a lot of our peers, our peer supports, we only have 2, but they started at a young age. And a lot of that, if you've never started something like that at a young age, you're not going to know what triggers it. But if you've been in that, you know it's usually trauma, right? And kids aren't going to talk about that with somebody who doesn't understand it. So if you have a peer support you can get to have those conversations, they're amazing. Did I answer that question?
Yes, ma'am. Yes, ma'am. So the next question is, when collecting the data, do you provide information on race, or is that kept anonymous?
We do not. The only thing we provide information on is gender and EBCI enrollment.
And Ms. Polk confirmed that, yes, you did answer her question. Do we have any additional questions for Ms. Ginger? These are all excellent questions. And great job making the responses so conversational, Ms. Ginger.
I can preach. I love harm reduction and mental health. That's my thing.
What does a typical day look like when you're doing this work? Great question.
So our program has a fixed site and we have a mobile unit that goes out. The fixed site dispenses from 9 to 5 and there's no closing for lunch or anything. So the team over there opens up. We advertise our program on social media and our hours are posted on the door. So our participants know if we're going to be closed or, if we're going to have limited hours or whatever. But it's just like any other. People just walk in and, they fill out they don't actually fill out the form. The outreach worker asks the questions and then gets the answers from the participant. And that was intentional because a lot of times you can get a lot of insight into what's going on in somebody's life by what they're not saying, by their body language, by their hesitancy to answer, by the way they don't look you in the eye if they're, if you're asking them about domestic violence or if they've been exposed to Hep C or HIV that they know of. So we didn't want our participants to have to come in and sit and fill out a form. We wanted that to be an interaction, a conversation. So they'll fill out their form. They'll say, how many times are you injecting? And based on that number and when they'll be back is how many syringes they get. And the only thing we track in our supplies is how many syringes we give out. Everything else is take whatever you want. We don't track the cookers. We don't track the ties. That's all done at the end of the year in an inventory, but it's not done daily. And that's it. They get their stuff. We ask them if they need anything. We make sure they've got water and crackers to take with them, and they go on their way. If we're having a vaccine pod there that day, if the public health nurse is there, then they're offered that vaccine. And if they want it, they get it. And if not, then we see them again.
Do you give out any smoking supplies?
No, I'm working on it though. I'm working hard, but we don't have any pipes or anything yet.
And how can one go about getting a Sharps box in North Carolina?
We give them out. We have small ones, and then we have, I think it's a gallon one, a quart and a gallon or a quart and 2 gallon, but we give those out to anybody. So even if people are not injecting like heroin or meth or anything, but they need a Sharps box to keep at their house because they may have heavy drug traffic through their house and they want a Sharps box there. We give that out to them. They get them from us. We have to pay for those. That's not covered by any grant. We have to order them from a medical supply company. Some of the stuff we can get through NASEN, NASEN, and they're a great resource to get your cotton and your the cotton juice for filtering, because we don't want people to use cigarette filters. We want them to use, cotton and tourniquets and stuff like that. But the supplies they don't provide, we have to order. We use McKesson, and that's who we order it from.
And just out of curiosity, let's say you have like another small, like a public health nursing office in the field. Are they able to reach out to you if they're in North Carolina for support and maybe getting, a couple of Sharps boxes?
Are you asking like if somebody's like our mobile units out in the field?
Correct. Let's just say you have like a CHR from another program that like does outreach, and they know that they have a household that they know that there may be a user in the household. Are they able to reach out to your program to maybe receive 3 or 4 boxes for their clients?
We try to keep our services somehow linked to the boundary. So it's either got to be somebody who lives here or somebody who's using them as somebody who's here.
Okay.
But if they contact our program, because our mobile unit might be out in that area. And if it's out in that area, then we can supply to whoever comes to the mobile unit. Does that make sense?
Yes, ma'am. And you talked about using Mason. Do you use federally funded, state, tribal, or private funds when you're buying your supplies and funding your program?
We do not have any state, to my knowledge. We do have a grant through SAMHSA that allows us to purchase non-injection, like we can't buy syringes with it. And then the tribe is the one that actually funds the day-to-day, the salaries and all that stuff. But we get as much as we can from the SAMHSA grant. And that's where we've gotten a lot of our hygiene kits and a lot of our cold weather clothes, bug spray, sunscreen. It's stuff that we don't think about because, we have it easily accessible. But when you're living on the street or out in the woods, it's stuff that you need that you can't get anywhere else. So we use that grant to get a lot of that. And our nasal Narcan comes from that grant.
Because this is a tribally funded, does the tribe request that the number be decreased? And do you have to follow the tribe's treaty rights? And she is willing to explain that question more if you would like for her to give you a little bit more so you can answer it.
If you're asking if we are trying to decrease the number of participants, we are not. What we are trying to decrease is the amount of Hep C, HIV, STIs, and endocarditis that has been traced back to the injection drug user population. We do have to follow all the tribal laws. And that's why at the beginning, when I was talking about the limited immunity, when we had that clause in there, it was not legal in the state of North Carolina. So that limited immunity would only cover somebody if they were pulled over and searched on the boundary. So if people leave the boundary with supplies or residual or residue in their syringes and they get pulled over and searched, or if they're walking and they get searched, whatever happens in that off the boundary is off the boundary. We don't intercede. There's really not a whole lot we can do. Is that what you were asking, or?
Ms. Pope, can you confirm that? Yes, you did answer it. So we have 5 minutes left. Do we have any additional questions for Ms. Ginger? I'm checking to make sure no hands have been raised. And there's no more questions in the chat box. And if not, I would like to take this time to thank you, Ms. Jen. Oh, here we go. Do you do referrals for recovery supports?
We do not do paper referrals. What we will do is connect people with recovery resources if that's what they're requesting. And we can actually make those phone calls while they're with us if they want us to. But we do not do a paper, like a hard handoff or anything like that.
Okay, I do not see any more questions, but you did throughout the presentation get a lot of kudos in the chat box, a lot of thank yous. So in Ms. Dree fashion, I would like for everyone to use your reactions if you are able to, and that show Miss Ginger some love, some thank you. Let's give her some flowers and some praise. And Ms. Ginger, I want to thank you for joining us today. Amazing presentation, amazing work. Your passion is there. You are a very selfless person. You love the tribe, you love the people, and that really speaks in how you speak about the program and this work. And you are one of those superheroes. So thank you. And thank you to the audience for all of you joining us. And I would like to take this moment to say that if you want to read more about how Miss Ginger feels about her work, please check out the health reporter. I will share the health reporter with you all. We did spotlight Miss Ginger and their Syringe services program and the work that they did during COVID. And so we definitely feel like Miss Ginger is one of those superheroes, as well as her team, and, you know, and every single one of you. So with that, thank you all. So we would not have so I just saw a question in the chat box. Are there going to be more of these? To Kimberly, yes, ma'am. We have a webinar every month. And these webinars are 100% based off of what attendees like yourselves tell me I want to learn more about. So if you shoot me an email or doing your survey, you say, I would like to have more information about ABC, I would do my job to get you more information about A, B, and C. So Miss Ginger was a hot topic. I was able to work with her. I love the passion. So I asked her if I can interview her. I will be reaching out to more facilities to do success stories on the work that they're doing throughout COVID. And so I would also like to note that we will have a session in July. Our next infectious disease regional institute will be in July. It will be July 21st in Montana. The official announcement for location, for hotel, we will be providing travel scholarships. All of that information would go out next week. So when I send the recording with the slides, I will also share the information about the next infectious disease regional institute. Again, it would be in July in Montana. And so we are definitely looking to see you all in person. And this is another session where we're going to deep dive and talk about some of those services in addition to more, you know, what can we do more in a community and more team-based care. So the utilization of community health representatives, as well as, you know, our pharmacy team. And so again, there would be no webinar like this next month, but we are looking to host a webinar on monkeypox, because I do acknowledge the emails that have come in about more information, what to expect for our tribal communities. So that is something that our team is working to bring you next month, but that would just be a call for everyone. So you don't necessarily have to be in infectious diseases. This just because monkeypox is a hot topic, and I just want to make sure that I am putting out the most relevant information as it comes. And so with that, thank you all for attending today. Please complete the survey so that I can share those results with Ms. Ginger. So, you know, these words would match with your words. So again, thank you all. Have an awesome day. Please drink some water. Please get out and enjoy the sunlight. Please share a smile. And thank you all for joining today. Thank you.
Thank you.
Bye-bye.